sorry, good evening to those in India. Sorry, it's very early in America.
Sir, Mahesh sir, where I can insert this slide, sir?
We can do it before the welcome.
After the welcome.
That didn't keep the formatting. Okay, you're doing great.
Where I can keep this 2 slides?
So Sheila, the first slide ఒకటి welcome delegates first పెట్టండి. Save the
Okay,
date last లో పెట్టండి.
Okay, sir. Okay, sir.
సార్ చెప్పేది.
If the date can go at the end of the presentation.
Yeah.
After the presentation?
Yeah, after the presentation. There.
Okay, na sir?
Yeah, మీ AIG పక్క దాంట్లో పెట్టండి last లో.
Good afternoon, everyone in India. We will begin in 10 minutes.
That's correct, Sushil.
Camera.
How do I remove this question the box?
You X out of
You
it.
just need where to see the questions.
No, I don't want to see that box now.
You don't want to see it now?
You hit the arrow again, Mahesh.
అది లాస్ట్ టైం తీసుకున్నాం టేబుల్ ఇంకా తిరిగి రావాలన్నమాట.
You can close out of it and open it up at any time. You can use the little X at the corner. Or the little box in the corner. I'm sorry, the little box with the arrow. It says dock pane to control panel. Attendees will begin in about 9 minutes. Now, Dr. Reddy, I do not believe that there's any audio associated with videos for this platform. So if you needed some audio, you'll have to just narrate.
Sushil, can you hear us?
I can hear
Sushil?
you, yes.
Yeah.
Yes, Dr. Reddy, Dr. Reddy was on mute, but now he's not. Perfect.
Nalini, you are starting?
We're going to start in 7 minutes.
camera లేదు.
Okay.
Camera tie this out.
లేదు యాక్చువల్ దీనిలో కెమెరా ఆప్షన్ చూపించట్లేదు. రెండు వైపులా కదా.
లేదు కరెక్ట్ చెప్తారా.
Attendees, we will start in 6 minutes. Dr. Gouda, are you going to read the moderator announcements?
Yes, I do. I will. I have actually a printout, and I didn't see the slides, but I do have a printout.
Okay. Dr. Reddy, as Dr. Gouda reads the slides, reads the moderator announcements, you can advance the slides for him. That's usually the easiest way to do it. But Dr. Glinka, are you going to do a little introduction for this slide?
I could, but we need to know whether Nalini is starting or I'm starting. Nalini, should I move, start with welcoming people and then you take over?
Yeah, if you want to read,
Whatever you feel.
you can do the first slide, and then I can do the introduction, and you can do the questions and the last slide. We'll leave the last slide on when we're doing the questions.
Perfect. Yep. Save the date. Mhm.
Save the date, yes.
Yep, that's great. Attendees will be starting in 5 minutes.
And I go up to about 40 minutes.
Okay.
Yeah, Nagi.
Yes, we try to
Nagi won't
end
be seen
right
on the
on
screen?
time so that the attendees can go, be with their families and things like that. So right at, I believe it'll be 6:30 p.m. for India time.
Yeah, that's true. We'll finish at 6:30.
Yes.
Nagi won't be seen on the
Dr. Gouda,
screen?
if you can keep
No,
an eye-
nobody's seen.
Hello?
It's just the slides.
Okay.
Me.
So Dr. Gouda, if you can keep an eye on your time, it'll be 6:38,
Hello.
7 a.m. your time, Dr.
Yeah,
Gouda.
Nagi? Nagi,
you hear
we
us?
can hear you. Yes,
Okay.
I can hear you, Nagi.
So I go about 40 minutes, Mahesh.
Yeah, 40 is fine. 40 is fine.
Yep.
We'll have about
It'll
1
be
minute.
2 or
in the
3 minutes for the introductions, then 40 minutes for the talk, and then there's still about 15 minutes for questions.
Okay.
And we'll have a list of who asked all the questions in case we don't get to one if there's something important.
We would do that.
Yeah. Attendees will be starting in 3 minutes. Presenters will be starting in 3 minutes.
Thanks, Benedict, for organizing all this. I know you'll be going mute in a couple of minutes, so.
Yes, I'll be muting myself soon. But thank you. Yes, this is wonderful. We're so thrilled to do this.
Looks like we have people trickling in slowly, both from the East Coast and the Far East in India.
Okay, this is a 2-minute warning. Actually, maybe that's the 1 minute warning. That's a 1 minute warning.
Yep, I got it.
My computer and my phone are off sync. Okay, Dr. Gouda, I'm sorry, Dr. Goenka, I'm going to tell you when it's time to get started.
Sure.
Because we're already live. So I'll just tell you when it's time. And then if you're not, once you're done speaking, Dr. Goenka, and then Dr. Gouda, once you're done speaking, we'll have you go on mute. Okay, we have 30 seconds. $15. Okay, Dr. Goenka, you can get started.
So this is Dr. Mahesh Goenka from India, Governor of ACG Indian region, welcoming all the delegates, whether you are in the USA, India, or anywhere, for this second ISG ACG webinar. And we have a very interesting topic which will be discussed by Dr. Nageshwar Reddy, the chairman of famous Asian Institute of Gastroenterology. I welcome everybody for this webinar and will hand over to my co-moderator, Dr. Nalini Gouda. Dr. Nalini, please.
Good morning, everyone in the US. Good evening to everyone in India. I am Nalini Gouda. I'm the governor of ACG Wisconsin. I'm here at GI Associates Milwaukee. It's my honor to co-moderate with Dr. Mahesh Goenka, who's the director of the Institute of Gastrosciences at Apollo Gleneagles Hospital in Kolkata, India, and the immediate past president of the Indian Society of Gastroenterology and the past president of the Society of Gastrointestinal Endoscopy of India. Next slide, please. Dr. Reddy. Next slide, please. So to participate in this webinar, all attendees will remain in mute. So you're only on a listen-only mode. So if you have any questions, please type them in the questions box. So you will not have a chance to ask the questions, but please type in your questions in the question box, which is on the right-hand side. You will see a pop-up box and you will see questions. You can type them there, and Dr. Goenka and I will gather all the questions and ask them, lump them together and ask them to Dr. Reddy. We will answer as many questions as possible at the end of his talk, and whatever we cannot ask at that time, we will send the summary of the responses. A handout with slides can be downloaded from your control panel on the right side. Next slide, please. Also, all the members of the American College of Gastroenterology are invited to attend the ACG annual meeting at Vancouver, Canada, October 20th to 25th. And next slide, please. Now, without wasting time, I would like to introduce Dr. Nageshwar Reddy, who Dr. Goenka has already introduced. His world-renowned endoscopist, gastroenterologist, who has received many awards and accolades, and he has kindly consented to do this international webinar, a collaboration between the American College of Gastroenterology and the Indian Society of Gastroenterology. Dr. Reddy, please take over.
Thank you, Nalini. I'd like to thank Mahesh, Nalini, the ISG and ACG for giving me this opportunity to talk in this very important forum of the virtual Grand Round. My topic is on endoscopic management of chronic pancreatitis, and I have no specific disclosures regarding this. Patients who come to us with chronic pancreatitis come mainly because of pain, which requires intervention, sometimes diabetes and malabsorption. But remember, pain is the main indication for intervention. The intervention for pain can be medical, endoscopic, or surgical, but the reason why these patients get pain is very clear, that they have obstruction here, either because of stones or strictures. That is what we should think. But the problem is more complex. We now know that it's not just the obstruction causing ductal hypertension which is causing pain, but there's local oxidative stress, local inflammation, there's pancreatic neuropathy, neuroplasticity, central neuroplasticity, and so on. So it's actually a very complex phenomena, and to think that with a single modality we can solve all the pain problems, I think is too early. In fact, most of these patients require a combination of therapy, but the main mechanism of pain, 2/3 of the patient, is because of ductal hypertension, and therefore all our therapies, both endoscopic, surgical, is aimed at decreasing this ductal hypertension. Now, In patients who have pancreatic stone, which is very small or impacted at the orifice, we can do an endoscopic therapy directly. We do an endoscopic pancreatic sphincterotomy. Usually the sphincterotomy is directed at, say, 1 o'clock position. And if the stone is stuck like this, sometimes you can occasionally take it out. But these are not usual things that we do. You can see very small stones, less than 5 millimeters, can be brought out with a pancreatic sphincterotomy. And in a large stone like this, in fact, I'm actually putting my leg on the ERCP table and trying to pull this stone out. This was a 5 centimeter stone, which is impacted at the ampullary region, which we could get out. But in general, most of these patients have stones which are actually not only large, spiculated, but stuck to the mucosal surface and in the ductules. And therefore, it's very difficult to remove them at endoscopy. And this is a picture that I borrowed from my surgical friend G.V. Rao. You can see how these stones are really stuck into the mucosa. So you can't generally remove them like you remove bile duct stones. The way to remove these stones is to do a combination of extracorporeal shock wave lithotripsy using the lithotripter that urologists usually use, and then break these stones into small fragments, do an endoscopic sphincterotomy and remove these very small fragments to clear the duct. This is the usual mechanism that is done. Now, in fact, this is a technique that's advocated in many guidelines as the technique of removing radiopaque stones, which are more than 5 millimeters in size, obstructing the main pancreatic duct. The ESG recommends this with a high level of evidence based on numerous articles that have been published in this area. But there's several factors which can influence the success rate of your stone extraction. One, of course, is the patient factors like stone size and density. Very large stone size or density of more than 5 centimeters are difficult to remove this way. Strictures, of course, cause obstruction and pancreatic clearance is difficult. Long duration of the disease and use of narcotics make it more difficult. There are very important technical factors which are not often realized. For example, the operator experience, the type of lithotripter we use, the anesthesia that we use, and so on. In fact, a combination of all this is very important. There are very specific lithotripters which are useful in this situation to break the stones, and not all of them, especially the ones the urologists have, are not useful. So don't send your patient with chronic pancreatitis with stones to urologists, because invariably they will not break these stones. You also require a very experienced operator who's only doing this. And more important, we have shown that if you use epidural anesthesia, this is a very effective way of breaking the stones rather than using general anesthesia or propofol. Of course, the end point of success is to break these stones into these very, very tiny particles of less than 3 millimeters, actually a powder, before you flush them out. And you can see here that once you break these stones and clear, the duct is completely clear. Sometimes the stones can come out spontaneously without an ERCP after the extracorporeal shock wave. And these are examples of stones actually coming out after ESWL. And you can see the dilated duct here is completely clear. In Europe, and especially units which are very experienced in this, do only extracorporeal shock wave lithotripsy and remove these stones without resorting to post-SWAL ERCP. But in our country and in many places elsewhere, we generally tend to follow SWAL with ERCP to clear all the fragments. Now, this is a large study that we published recently, over 5,000 patients. You can see the stone clearance with SWAL was 72%, partial clearance 17%. Only in about 10% of the patients, we're not able to clear the duct either completely or partially, indicating that if we have the proper equipment, the proper operator, and the proper technique, then you can clear these stones in majority of the patients without any problem. Now, this is a systematic review and meta-analysis published by Janine and a group in endoscopy. We showed very clearly that in patients who have had extracorporeal shock lithotripsy, both for pain and stone clearance, you can actually get a fairly high rates of success. Almost 2/3 of the patients are pain-free, and over 85% of the patients you can actually clear the stones. Now, there's a certain group of patients who would respond better. For example, those who have shorter duration disease, those who have intermittent pain, those who are not on narcotics, these are the patients who would respond better. So in general, Endotherapy is effective for stones in the head region, disease duration of less than 5 years, if the pain is intermittent, if there's no narcotic use, which is again very uncommon in United States, but very common here in India and rest of Asia, and of course in non-smokers and non-alcoholics. These are the group of patients who would respond quite well to endoscopic therapy. And the reason why results from the West have been very poor is because of this, that most of these patients are already on narcotics before they come to the doctor. What about the long-term results? And this is very important because most of these results have to be compared over very long-term, like in surgery. This is the first study that was published several years back from Jack Davies unit, which showed that when they followed a group of patients for more than 11 years, you can see that a good percentage of them had no relapse of pain and also no hospitalizations, indicating long-term efficacy. This was our study published again sometime back where we looked at two groups of patients, those who were followed up for intermediate duration, 2 to 5 years, and those who were followed up for longer term, up to 10 years. And you can see that in 2/3 of the patient, there was pain relief even after 10 years. Some of them required re-intervention, and those who required re-intervention could be successfully treated without any problems. So in general, endoscopic intervention, if properly done, is effective even on long term, and 2/3 of the patients are pain-free even after on follow-up. There are, of course, several problems with extracorporeal shock lithotripsy, especially in, I think, United States. It's not broadly available. You are dependent on your urologist. And if you actually look at this data, a comparison of urologist versus gastroenterologist directed extracorporeal shock lithotripsy, you will see that gastroenterologists are much better. Urologists are, of course, not trained for this. Their stones are much smaller, and they require more expertise to actually break the pancreatic stone. So therefore, depending on the urologist may be not the right thing to do. And that's why you see that this problem of SWOL in most countries, especially in North America, it's a problem. And of course, there are reimbursement issues. So some have tried to do this intraductal lithotripsy, whereas you use a pancreatic scope. In this case, the whole mother and baby pancreaticoscope. And using EHL, you can see that these stones can be fragmented completely. Of course, EHL under vision is fairly good, otherwise it can cause damage to the pancreatic duct. But using this technique, we can completely clear the pancreatic duct. But more often, a combination of using the SPY cholangioscope, the SPY DS scope, along with laser is the most common technique that has been used. Again, several reports from North America using this technique for patients with stones in the head region, limited only to the head region mostly. And you can see these stones can be completely fragmented and the duct is cleared. There are several technical problems with these techniques because of the strictures that are present, because of the curvature of the pancreatic duct and so on. But the advantage with pancreaticoscopy is that most units have it already because they're using cholangioscopy. It's only in one session you can do the whole procedure. There's no dependency on your urologist or other departments to do your stone. That's why it looks very attractive. But unfortunately, in my opinion, pancreaticoscopy is not technically adequate to break most pancreatic stones. There have been several studies, almost 16, which have been published over the last 20 years, 300 and odd cases, with high technical success rates, low adverse events. But you must remember that most of these studies are published from units which have a huge experience using these pancreaticoscopes. They have a limited number of cases, and of course, the pancreatic stone volume is extremely low. And therefore, you see this very short-term high clinical success rate. But in general, this is not the ideal technique to break pancreatic stones. There's been one study from Stuart Sherman's unit which compared extracorporeal shockwave with a SPY scope lithotripsy of pancreatic calculi, showing almost equal efficacy. But again, you must remember that these are very specialized cases, small volume of pancreatic stones. In general, I would not recommend this as a technique to break pancreatic calculi. So extracorporeal shockwave still remains the main method of treating pancreatic calculi. Now, many of the patients with chronic pancreatitis, in addition to stones, have strictures. And this varies depending upon the etiology. If you look at the etiology in general in patients with chronic pancreatitis, about 50% of them have strictures. In patients with alcoholic pancreatitis, a little more have strictures associated with stones. So these also have to be treated. And of course, the treatment of these is using a pancreatic stent. Several years back, Michel Kramer introduced the technique of using a plastic pancreatic stent in these patients. And then this was further modified by Guido Castamagna, where not single stents, but balloon dilatation is done and multiple stents are put in, just like for treating benign biliary strictures. And you can see here 3 or 4 stents are put in. And the stents have to be put in at least for a period of 1 year before they're taken out. If they're taken out too early, the strictures do not open up completely and recurrence is very common. So this is the technique that has been used. Usually this is useful for proximal strictures. Multiple stents have to put, and stenting has to be done for 1 year for real success to occur. So these are some of the issues that are involved in pancreatic stricture stenting. The Korean group actually started using completely covered metal stents, and this is a type of stent called the bumpy stent. Large series have been reported from Korea. We've had considerable experience with this in India also, where these stents are put in for tight strictures. They open up completely, but the problem is some of these stents can themselves induce strictures, as you can see here. These are transient and open up, but still it's important to remember that these stents are not totally safe. But for resistant strictures, not responding to plastic stents, it may be worthwhile to think of putting in these completely covered specialized stents, the so-called bumpy stents. Now, this is regarding stents, strictures and stones. In general, when you're treating patients with stones and strictures in combination, we not only do extracorporeal, but put these stents for a brief period of time, remove them, and then clear the stones completely. But there are also other problems in chronic pancreatitis which require endoscopic therapy. For example, when pain sometimes is not responding to all this celiac ganglion block, which of course I'll come to a little later. Pancreatic fluid collections in associated with chronic pancreatitis require drainage like any pancreatic fluid collection, but mostly with plastic stents on long-term basis. And of course, we can use rendezvous technique with endoscopic ultrasound. But sometimes in patients who have a very difficult ERCP, we might have to use an endoscopic ultrasound to enter the pancreatic duct and of course drain it transgastric also. In patients who have pain which is not responding to other forms of therapy, on rare occasions we have used celiac ganglion block, but again this is not recommended because this is a very short-term period. And of course, after 6 months, patients get their pain back again. So this is only used in a desperate situation, non-dilated ducts, not responding to other forms of therapy. And here we have shown that endoscopic ultrasound-guided celiac ganglion blocks are better than percutaneous ones. Of course, there are a group of patients who develop biliary strictures with chronic pancreatitis. In these patients who have biliary strictures, we would like to use stents to open up these strictures. So again, there's a lot of controversy in this area. I'll go a little into this, but the type of stents we have shown several years back, the best stent to use in these cases is a completely covered metal stents. These stents stay in place for 1 year, and after removing them, the strictures tend to be open. So in patients with benign biliary strictures in chronic pancreatitis, one can use a completely covered metal stents to open up the strictures. Now, how does this compare with multiple plastic stents? This is again a paper recently which came, a multicentric one, predominantly led by our unit, where we randomized patients with benign biliary strictures following chronic pancreatitis into 2 groups. One group had multiple plastic stents, 84 of them, and one group had fully covered metal stents. These were put in for 12 months, removed, and we followed it for 12 more months. And you'll find here the stricture resolution is similar whether you put multiple plastic stents or metal stents. The side effects are similar, adverse reactions are similar, but the number of ERCPs required with a completely covered stent is much, much less compared to plastic stents. And therefore, we believe that if you're treating patients with chronic pancreatitis biliary strictures, it may be worthwhile to think of putting in a single completely covered metal stents and removing this after 12 months. Endotherapy is ideal if the stricture size in the bile duct is less than 3 centimeters, there's an absence of head mass, and very often absence of calcification in the head. With these 3 types of situations, endotherapy is often successful. Now, in literature, there's a lot of debate whether we should do surgery or endoscopic therapy. In fact, there are several papers which seem to support surgical therapy. But to a large extent, it depends on several factors upon the experience of the unit which is treating these patients, the size of the stone, the location of the stone, and so on. In fact, if you have stones like this in the head region, which can be very easily broken by endoscopic therapy and extracorporeal shockwave, then endoscopic therapy is the answer. But if you have calculi like this, not only in the duct, but extending into the body and sometimes to the tail, here it depends upon the experience. If the surgical experience is good, you go for surgery. But if endoscopic experience is good, maybe you can still try endoscopic therapy to clear these stones completely. But in a situation like this, where there's multiple stones all around, strictures the pancreatic duct, actually the pool of lake appearance, in these type of situations, I think one should resort to surgery. The most important contraindication to endoscopic therapy and also the indication for surgery is a pancreatic head mass. If you have a mass in the pancreatic head, these patients should not be subjected to endoscopic therapy and should go for surgery because the response to endoscopic therapy is poor. And some of these patients may actually be harboring a associated malignancy, which is common in these patients, and one should not miss this type of lesions. So in the management of chronic pancreatitis, there are two approaches, the step-up approach and the individualized approach. In fact, there's again a lot of debate in this area. And let me come to this. For example, there's a view that if you have a patient with chronic pancreatitis, we advise him to stop smoking, start him on analgesics, smoke alcohol and smoking, of course, and start analgesics. We use neuromodulators. Of course, now we know that pregabalin group of drugs are very effective. Pancreatic enzymes, especially the uncovered ones, and antioxidants. Using this combination, we start therapy. If there's no response, we go for endoscopic therapy. If there's no response, we go for surgery. This so-called step-up approach is advocated by some group of workers in chronic pancreatitis. But the criticism against this is that by the time the patients go for surgery, all forms of therapies have been done with, and they don't respond to surgical therapy because many of these have already gone on to narcotics. And therefore, one should not go for this form of therapy. Now, as I told you, surgery versus endoscopic therapy, there's a lot of debate in literature. In fact, the first studies that were published in New England Journal in 2007 from the group from Netherlands, a multicentric study showed that when endoscopy was compared with surgery, the pancreatic surgery was much better. There's since then been a lot of debates about this and so on, and long-term follow-up of these cases, again published in Gastroenterology 5 years later, showed that surgery still continues to be better. But I think it's important to remember that although surgery is supposed to be better in these patients, there's several small dots that have been missed when analyzing these results. And let me show you this very clearly in this ESCAPE trial, which was published in JAMA in 2020, where it was clearly shown that surgical therapy is better than endoscopic therapy in relieving pain in patients with chronic pancreatitis. But actually, if you sub-analyze this data much more, you'll find very clearly that when you look at this, if you take the patients who had endoscopic therapy and divide them into two groups, those who had complete clearance of the duct and those who had only partial clearance of the duct. Those patients who had complete clearance of the duct endoscopically have a response which is as good as surgery. Those who have partial clearance had response which is not good. So you can actually carefully look at this study and you'll find that the response to endoscopic therapy is equivalent to surgery. So therefore, comparing endoscopy and surgery is not so easy. The groups are very heterogeneous. One has to be very careful. And therefore, that's the reason why I think we do not take this publication so seriously now. And one would have to depend upon the local experience in the unit. There are, of course, several problems when trying to compare and several problems in the studies, the quality and limitations of the studies, the heterogeneity of the population, and most importantly, the difference in the operator experience when many of these studies are being done. And therefore, I think it's very important that one should actually follow the protocol that is set up in one's unit. Now, what is the protocol? What we require to do in future is to have adequate tools to assess pain, We require sham control studies which are coming up. We require patients who hadn't had drug therapy and narcotics before, confounders like alcohol, smoking. It's also very important, the timing intervention. We know that early intervention is extremely helpful in these patients compared to late intervention. And of course, we require long-term studies of more than at least 10 years in these groups. Nevertheless, the way we actually treat these patients now is sort of getting standardized. And this is what I call the individualized approach, unlike the top-up approach, which is followed by some. I would suggest that we should treat these patients in an individual way. For example, if we have a patient with chronic pancreatitis who has pain, which is the main indication for intervention, the non-dilated ducts are given medical treatment, which will include pancreatic enzymes, which are not completely coated, analgesics, non-narcotic, and of course, pregabalin type of drugs. If they don't respond, and sometimes you are very desperate, you can do celiac ganglion block, but we are not for this. In those patients who have complications, for example, pseudocysts or walled-off necrosis, these have to be treated separately. The most easy patients to treat with those with chronic pancreatitis are patients who have dilated ducts. These patients who have dilated ducts and caliculi, either multiple or single, can be treated with extracorporeal shock lithotripsy. Very rarely, if the stone size is less than 5 millimeters, you can remove it endoscopically, but most often these patients require extracorporeal shock lithotripsy to break these stones into small bits. If there's associated strictures, we can put stents in these patients, and this again a period of 1 year. So combination of extracorporeal shock lithotripsy, stenting, and endoscopic therapy would be successful in about 80% of the patients. If they do not succeed, then you can go for surgery. This is the very individualized approach that we offer. But there are two groups of patients whom we would refer to surgery immediately. That is, we don't wait for endoscopic therapy. First is a group of patients who have a head mass, especially the suspicion of malignancy. This group of patients should go directly for surgery, not for endoscopic therapy. The second group of patients are those who not only have multiple stones, but multiple strictures in the pancreatic duct. These cannot be treated by endoscopic therapy, and it's better that these patients go for surgery. Most of the failures of endoscopic therapy, in my experience, what I've seen all around is these are the group of patients with stones and strictures. Endoscopic therapy is tried in several centers. Finally, these patients, when they go for surgery, they have several complications because the surgeons find it difficult to operate on these patients whose stents have partially migrated, infected. There's a lot of inflammation around the pancreas and pancreatic duct, and surgery becomes more difficult. So that's the reason why this group of patients should be directly referred for surgery. So this is a sort of systematic approach or individualized approach that we use to treat patients with chronic pancreatitis. But finally, it's important to remember that these patients are treated in a teamwork. Whenever we see a patient with chronic pancreatitis, it has to be approached by the physician, surgeon, endoscopist, and intervention radiologist, because each of them have a role to play. And based upon what is best for the patient, we should decide. So a group of patients can go for endoscopic therapy or some directly for surgery. But there is a significant group, I would say about 70% of the patients who do not require endoscopy or surgery, who are treated with medical treatment, mainly with pancreatic enzymes and analgesics to decrease the pain. And I think when you have this teamwork, these patients are treated together, most of the success would occur. Again, I'd like to thank ACG and ISG for giving me this opportunity to talk on this very complex subject. There are a lot of narcissists here, I realize, and I'm sure we can take up any questions that come. Thank you very much.
Thank
you, Nagi.
Thank you, Dr. Reddy, for covering a broad topic in a short period of time. We do have some questions, and Mahesh, before you start the question, for the audience, I'd also like to invite Dr. Matthew Phillip, who's the secretary for the ISG, who has joined us on this meeting, though he will not be able to talk and ask any questions. Welcome, Matthew. And we'll start off with the questions. Mahesh?
Yeah, so there are a couple of questions on the chat box. Nagi, before we have some questions for you, The first one is that you did talk about urologists and gastroenterologists managing the stones of their area. The question is that what's the difference? Are we using different energy levels in ESWL compared to the urologist? Why the same machines cannot be used? This is a question from Dr. Nikhil Kumar Joge, I'm sure from India or maybe from USA. So Nagi, will you like to address that question?
Yeah, I think that is a very important question because the study clearly showed that gastroenterologists have better success rate. But basically, it's very clear. The reason is that, first of all, the machine that the urologists use are very low energy machines. The renal stones are very easy to break. They have a very high calcium content. They're very brittle. And usually about 1,000 shock waves are enough to break these stones. And most of these machines don't have a very intense focus that is required. The machines that we use for pancreatic stone therapy are very high-end machines, are extremely costly, so urology units do not have them. They have a very high focused intensity, and normally we require about 10,000 shocks to break these stones. So the energy levels are completely different, and these high-end machines are not available with most urologists because there's no point in having them. Number one. Number two is the operator experience. For urology, again, if you look at, because the number of shocks are very low, the amount of time spent is very less, the operator experience is very less. Pancreatic stones, of course, are not only, you require a much longer time, on an average you require about 1 hour to break these stones. And with the respiratory movements, the movement of the pancreas, which is there, the stone has to be focused exactly coinciding with the respiratory movement. And therefore, the amount of energy that is delivered should go to the center of the stone. So this is not possible in urological circumstances with urological machines. And of course, the amount of shock wave is also much higher. Third important thing is how we sedate our patients. Urological patients usually get sedated with propofol, very rarely with general anesthesia. And again, this I don't think is an adequate method to clear the stones, because when the patient is on propofol, for example, the breathing exertions are very high, and whenever the shock wave hits, it may not hit the stone, it hits on either side of the stone. That's the reason why in epidural analgesia is very important to have very high success rates. So for all these reasons, success with the unit which belongs to a gastroenterology unit is much higher.
Thank you, Nagi.
Thank you, Nagi.
We have another question from Agazi Gabrielesi. The question is, I know you talked about stents in the pancreatic duct, and you talked about placement of a metal stent. Now, in biliary stents, we typically tend to change them every 2 to 3 months. Would you go back and change the stents here, or would you just leave them alone for 1 year as you talked?
Okay, yeah, that's a good question. So it depends upon what type of stenting. If you're using plastic stents, what we generally do is progressively increase the number of stents every 3 months. We start with 1 or 2 stents, usually 2 7-French stents. After 3 months, go to another 7-French stents. After 6 months, go to another 7. So 4 7-French stents, and keep all these stents together for about a year and then remove the stents. So we do it every 3 months. There are some units, for example, like Guido's unit, where every 3 months, all the stents are removed and new set of stents are put in. These are 2 different protocols. In our unit, we just progressively increase the number of stents every 3 months. Now, if you put a metal stent, I would suggest not to take this out and replace it. A metal stent, the nature of the stent, like for example, the bumpy stent can be kept for 6 months without taking it out. So these stents typically are put between 3 to 6 months. Some units, the protocol is for 3 months. In our unit, it's for 6 months. And after 3 or 6 months, you can remove the stents once for all. You don't have to replace them. So plastic, 1 year, repeatedly done. Metal, only once between 3 to 6 months.
Great. I know
European Society of Gastroenterology,
sorry. So even bumpy stents tend to migrate, don't they? I mean, they're not completely migration proof.
No, bumpy stents have a migration rate which is lower than the standard metal stents because they're constrained in such a way that the areas which are very stiff and areas which are very soft. So this does 2 things. It allows the pancreatic juice to flow along the side. And the second thing is, because of this variability in stiffness, the migration rates are low. The migration rates of bumpy stents are about 10%, much lower than the standard completely covered metal stents.
Okay. Mahesh?
Nagi, while we are at the size and the number of the stents, the European guideline says that you should always put a 10 French stent. So your initial stenting would be a single 10 French or 2 7 French.
So I know the European ESG recommendations for stenting somehow doesn't fit into the protocol that we follow or follow in other units, because single 10 French stent is not going to be useful. Our policy is to start with 2 7 French, or if you can put 1 10 French, 1 7 French, even that is okay. But we like to start with multiple stents. And the single 10 French we put, you must quickly call back the patient after 3 months for the second, at least another 7 French stent immediately. So single 10 French stent on long term is not good for pancreatic strictures.
So there's another question, Nagi, from Dr. Abhirup Chatterjee, who wants to know whether the enzymes and antioxidants should be added to endotherapy in patients with large duct disease, or once you're doing endotherapy, there's no role for enzymes and antioxidants.
Yeah, again, that's a very good question. Patients in whom endotherapy is done, it is better to give pancreatic enzymes, because pancreatic enzymes in this situation is given for pancreatic insufficiency. In spite of putting in stents, these patients have chronic pancreatitis, the pancreas is completely gone, and they don't have enough enzymes, and therefore enzyme supplementation should be given for malabsorption. We don't give enzymes for pain in these patients. Similarly, antioxidants are not needed because they're predominantly used for pain. So after pancreatic endotherapy, it's predominantly enzyme substitution. But if the patient has mild pain, then you can give a combination of uncoated enzymes and antioxidants. But usually plain enzymes is sufficient in most cases.
So Nagi, I know you have a lot of experience with SWAL. We know it's safe, but what are the complications one should explain to the patient? That's a question from Dr. Sidhu.
Yeah, so again, SWAL is a very safe procedure. Our experience with over 10,000 patients now, both for pancreatic and bile duct stones, has been very good. In pancreatic situations, some patients can develop pancreatitis, especially if you do SWAL and wait for a long time before you do an ERCP. That is, we normally schedule it on the same day or next day. But if you wait for 5 days, 6 days, or a week, then the small fragments as they're coming out can result in pancreatitis. SWAL itself doesn't produce pancreatitis because these patients have chronic pancreatitis anyway. The second problem occasionally we have faced is in some of these patients, especially if the shock waves hit the kidney for some reason, hematuria can occur. We've had one rare patient who developed paraparesis, which recovered slowly because one of the spinal arteries was hit by the shock wave, and there's a mild bleed which occurred into this area. And of course, because you're using epidural, you can also have complications with epidural itself. In bile duct situation, SWAL can be associated with hemophilia, especially intrahepatic stones. When you're trying to break them, hemophilia can occur. So hemophilia, pancreatitis, hematuria, and very rare spinal cord problems are reported can occur with SWAL. But in general, it's extremely safe.
Now, there's a question. Is there any correlation between ductal dilatation and pain in response to pancreatic endotherapy? So is there any correlation between the degree of ductal dilatation and the response to endotherapy? Again, the answer is no. The amount of dilatation, you can sometimes have very dilated ducts and no pain. You can sometimes have small ducts with severe pain. In general, the correlation is between ductal pressure and the pain. This has been shown that very high ductal pressure can have pain, and decrease in ductal pressure can decrease pain. Some of this work has been done very early on, and recently there's some work going on where we're trying to measure the pressure in the pancreatic duct to correlate to the degree of pain and relief of pain after endoscopic therapy. These data are due to come out, but there is some correlation. But the duct size actually down. The reason is the duct size depends upon how quickly the obstruction occurs and how slowly the ductal dilatation takes place. If the obstruction is occurring very acute, for example, if the stone has migrated from the proximal part of the duct and gets impacted in the papilla, then you can sometimes get sudden pain without much ductal dilatation. But most of the ducts are dilated over a long period of time with stones being impacted, and therefore the correlation is not very good. So in short, there's no correlation between the ductal size and the intensity of pain.
Do you routinely do a pancreatic sphincterotomy then to relieve the ductal pressure if the pressure is the issue?
Yes. In patients in whom we are doing endoscopic therapy to clear the calculi, we almost always do a pancreatic sphincterotomy. And in many of our patients, we add a balloon dilatation also because these patients have a pre-papillary stricture. So we do a sphincterotomy followed by a balloon dilatation up to 10 mm before the stones are extracted.
There's a question from Matthew Philip from Kochi. There are two questions. One is that in a patient with acute attack in a setting of a chronic pancreatitis, when will you like to do the ESWL? How many weeks later after the pancreatitis settles down? And the second question is that in benign biliary stricture, how do you prevent migration of fully covered stent?
So in patients who have acute and chronic pancreatitis, we wait for 4 weeks. We would monitor these patients with amylase lipase to see why, especially lipase. And after 4 weeks, if it's back to normal, then these are the patients. So ideally is 4 weeks. Now, migration of the fully covered stent, in our study, which we published in gastroenterology, we didn't do anything. The stents were put in, about 20% migrated. But nowadays, what we're doing is that we put in a completely covered stent in the bile duct. And in this, we put in a double pigtailed 5 French stent. So these 5 French stents actually anchor the covered metal stent also, and migration rates are almost negligible. So I would recommend that if you're putting in a completely covered stent in a patient with benign biliary stricture, to add a double pigtail 5 French stent in this situation to decrease the chance of migration.
So Nagi, we have another question which is very interesting. You have various etiologies of chronic pancreatitis and you have a large series of SWAL patients. Does the response of CP and SWAL, is it dependent on the etiology? Does one do better than the other? It's a question from Dr. Mitchell.
Very important question. If you look at our series, about 80% of our patients are due to so-called idiopathic pancreatitis or genetic pancreatitis or so-called South Indian pancreatitis, tropical pancreatitis, various names. In essence, most of these patients don't have an etiology like alcohol, smoking, and so on. Many of them have a genetic background causing this pancreatitis. These patients have large ducts, large stones, strictures are not very common. So they respond typically very well to endoscopic therapy, and that's why our response rates are so high. Patients with alcoholic pancreatitis or where smoking is predominantly the cause, these patients have much less dilatation, they have strictures, they have stones which are much harder, and therefore endoscopic therapy is more difficult. We actually compared the success rates of endoscopic therapy for this group of patients with alcoholic or smoking-based pancreatitis versus those who are tropical pancreatitis, and we found that the success rates with those who have, even if you select your patients carefully, those who are smoking and alcohol, success rates are only 70% compared to 80% initially with the tropical pancreatitis, so less success rates. Of course, one of the additional reasons not only is the anatomy, but most of these patients continue to smoke or take alcohol even after the endoscopic procedure, and therefore they don't do so well. So it's a combination of anatomy and a combination of etiology continuing in these patients. So the answer is that patients who have alcoholism or smoking as etiology do less well compared to those with idiopathic pancreatitis. Even despite the genetic problems that the South Indian pancreatitis patients have. So you agree that, like in the West, that the studies show smoking is probably worse than any etiology for CP. Yeah, do you insist that patients stop smoking before you do endotherapy? Yeah, so that is also a very difficult question. So we have a very small group of those in our only smoking as etiology. We try and tell our patients to stop smoking at least for 3 months before take them, but usually it's not possible. For majority of them, smoking is looked at as a very benign procedure, and therefore not all of them would stop. So if they're continuing to smoke, if they're continuing to have pain, you'd still go ahead and do endotherapy, hoping that on the way they stop. But those who don't stop, the response is only about 50%.
Nagi, one question is that, a little provocative question is that, how will you offer endotherapy for somebody who does not have pain, but has a diabetes? Second is, do you suggest endotherapy for stones limited to the tail of the pancreas?
Yeah, this again, the simple answer for both is no. For those who have no pain, only diabetes, for example, or even only malabsorption, there's no evidence to suggest that endotherapy is useful. In fact, if it's only diabetes, we would discourage the patient even seeking it. And for malabsorption, although there's one study which showed some partial improvement, I would strongly recommend not to go for endotherapy only with this. So for diabetes or malabsorption without pain, we should not do endoscopic therapy. The second question is, for if the stones are predominantly in the tail region, there are no stones to the right of the spine. Again, I would recommend that endoscopic therapy should not be done. These patients are better subjected to surgery.
So Nagi, on the same principle of elevated intraductal pressure and causing damage to the rest of the gland because of ischemic changes, the initial pathophysiology slide that we have illustrated, would it make sense that you relieve the ductal pressure so that the body and the tail of the pancreas does not atrophy, and hence maybe there's some benefit in improvement of either the exocrine or endocrine function? I know there are no data, but do you think that it would work?
Without pain? Without pain?
Without pain. Suppose somebody comes to you with a large stone dilated in the head and a dilated duct, and it's not uncommon, right? You know, patients get scans for various reasons, and sometimes they are sent to you. Patient is completely asymptomatic, but they have a stone in the head of the pancreas, dilated duct. Would you offer endotherapy?
No. In this group of patients, I would not offer endoscopic therapy because, one, there's no evidence that endoscopic decompression actually decreases the progression of disease. And again, what happens is sometimes endoscopic therapy itself can cause problems. When they don't have pain, you can actually induce pain with endoscopic therapy. There's one very early small study which actually was published by Nealon, a surgeon, many, many years back, who showed that decompression surgically in early pancreatitis can decrease the progression of disease. But this study has never been duplicated, and especially in the endoscopic area has never been really shown to be true. So therefore, if the patient does not have pain, even if there's a dilated duct, I would not recommend endoscopic therapy to decrease the progression or to decompress the duct.
Okay, thank you. Because it's a clinical problem. You do get these patients routinely sent.
I agree. Yeah. In fact, we get pressurized a lot. A lot of patients come and say, okay, you say it's non-invasive, why didn't you do it? What's wrong? I mean, at the most, nothing may happen. But I think it's also important to tell them that this is any procedure, endoscopic procedure, even if it is less invasive, still has a potential complication. And that's the reason why we should not offer this to any of our patients who do not have a real indication for this.
Yes,
Right?
Mahesh.
Nagi, there is a question again from Matthew Philip. Is that endotherapy and LPJ surgery both work on the same principle, reducing the intraductal pressure? So why should surgery be useful in patients where endotherapy fails?
Yeah, so this is a question that we often debate with the surgeon, and there are a couple of things. One is that the opening decompression which the surgeon creates is much larger. We just create a small stent to decompress, whereas the surgeon is giving at least 3-4 centimeters opening. So the duct is completely decompressed. So in terms of decreasing the ductal pressure, surgery is definitely superior to endoscopic therapy. The second is, of course, when they do an LPG, they actually can scoop out all the stones, which we can't do endoscopically. And the third thing is when they're doing an LPG, they actually cut the capsule of the pancreas. So there's some amount of denervation that's occurring at that point of time. And therefore, pain relief is much better. So these are the three reasons why LPG is superior to endoscopic decompression. But majority of our patients who go for surgery actually have a combination of phrase, that is head coring along with LPG. And we know that the head is actually the pacemaker for pain. And once you do a coring of the head, that causes relief of pain. In fact, there's a controversial suggestion that the cause of relief of pain when you do extracorporeal shockwave is not only decompression or fragmenting the caliculae, but also causing little denervation. That is, the nerves around the pancreas actually you're sort of causing injury to them, and that may be also partly the reason why pain is decreasing in these patients. But anyway, surgery definitely is superior in that sense, but of course is much more invasive, and therefore that's the reason why endoscopic therapy would be preferred first.
And again, another question.
Our president Sandeep Nijawan has sent me a couple of questions on the WhatsApp. And one of them is that how do we know whether the benign biliary stricture is inflammatory or fibrotic? And can that be responsible for difference in the response to the metal stenting?
Yeah. So again, this is a very important. Yeah, it's an important point. In fact, if it's plain inflammatory, we'd like to wait for some time because inflammation comes down, the stricture opens up. So what we would normally recommend is that if we see a patient with a benign stricture in chronic pancreatitis, we would look at the LFTs, liver function tests, and the most important thing is alkaline phosphatase. If the alkaline phosphatase continues to be raised for more than 4 weeks, the chances that it's a fibrotic fixed stricture is more than its inflammatory stricture. So the criteria for putting in stents in these patients is to demonstrate at a gap of 4 weeks raised alkaline phosphatase, at least 3 times increase in alkaline phosphatase consistently present for more than 4 weeks. So this would be an important area. And of course, you also look at other parameters. For example, an ultrasound shows inflammatory head of the pancreas, then you have to be very careful that this could possibly be an association with that. Or if there's an associated fluid collection in the head area, that also will indicate that this is inflammatory stricture. So all these things are very important to differentiate between inflammatory stricture and a fixed stricture because of fibrosis. But that's a very important point. And again, I'd like to emphasize that you wait for at least 4 weeks before you do the bile duct stenting.
So Nagi, the other question is, what are the basic properties of the PD stones that are so hard to remove when they?
Yeah, one is, of course, they have a high extent of calcium, but more important is these stones are actually spiked. They get stuck into the mucosa. When you, in fact, open up surgically also, it's very difficult to remove them. And many of them are in the ductules, in the small ductules, and then you can't reach those ductules along either with a basket or a balloon. So that's the reason you can't. In fact, they're not like free-floating stones of CBD. They look like they're arising from the mucosa, stuck to the mucosa, and that's why it's so difficult to remove them.
And Nagi, when you do, how many sessions of S-wall do you recommend, and what interval should they undergo S-wall?
When we do S-wall, generally we would recommend at a single session about 10,000 shots, which means stones up to 2 centimeters can be broken completely in a single session. If the stone volume or stone size is large, then we would recommend 2 or 3 based upon the stone volume. Each session is about 10,000 shots, and if S-wall can be done every day, that is sequentially every day till the stones are completely broken. In majority of the patients, we use 1. In some patients, we use 2. In a small group of patients, we use 3. Generally, not more than 3 sessions of S-wall.
Mahesh.
Nagi, there is a question from Dr. Virendra Tiwari from USA as to how does the metal stent in the pancreatic duct prevent blocking of the side branches?
Yeah. So this again is a very important point. We've been trying to look at how metal stents, because theoretically, if you put a metal stent, it should completely close the side openings and drainage should be problematic. But the bumpy stent, what we use, is got a variable stiffness. So some part of the stent is a very low stiffness, and this forms a hollow there. The secretions can come there and slowly trickle out from the side. The standard metal stents that are used in the bile duct may not be suitable for these reasons. Also, some of the companies are now starting to make specialized pancreatic stents with this in view. There is one stent which is made by one of the companies in US, which has got holes on the side of the metal stents where pancreatic secretions can drain. But the problem is we can't assign these holes exactly to side branches. And second, if there's tissue overgrowth into these holes, then the stent can get fixed. And therefore, I would not recommend this stent. But currently, the only stent that can use safely the so-called bumpy stent with variable stiffness. And because of this variable stiffness, the pancreatic secretions can flow from the side of the stent out.
So Nagi, there's another clinically relevant question that has come from Dr. Moni is, the majority of the patients with chronic calcific pancreatitis, by the time, at least in the United States, they see us, they're already on opiates and they're opioid dependent. What would be your approach? Is there some sort of a step-up approach we need to adopt, or would we offer endotherapy right away?
So this is a problem. I think this is the biggest problem in the United States is that majority of these patients have already started opiates. And once they start opiates, I think it is very difficult to treat these patients with endoscopic therapy because they then don't respond. And this is very clear from several studies. Fortunately, this is not a problem for us. We don't deal with this at all because we do not, most of these patients do not require, the maximum they may receive is tramadol, which is still okay. But if they go beyond the codeine or codeine group of substances which they receive in the United States, actually has a problem. In that sense, they don't respond. It is very difficult to take out these patients from codeine. I don't know if there's an answer for this, Nalini, whether we can reverse them from these drugs and start treating them either endoscopically or surgically. But the biggest reason why endoscopic therapy and to some extent surgical therapy fails in US is, I think, because of this narcotic, I call it addiction also, because an epidemic of narcotics used there.
Yeah, Matthew again wants to know that chronic pancreatitis is a pre-malignant condition. So does endotherapy or surgery in the form of a LPJ would change the risk of malignancy?
Yeah, this is an interesting question, and there's been a debate on this. There is no evidence in literature that either decompressing the pancreatic duct, LPJ, or endoscopic therapy alters the natural history to the extent that incidence of malignancy comes down. The only thing is that when you do these procedures, these patients are more careful follow-up, so you pick up malignancies earlier. But in general, there is no evidence that endoscopic intervention or surgical intervention decreases the incidence of malignancy in these individuals.
So we are coming to the top of the hour here. I'm going to ask the last question, and whatever we cannot answer, I think we did manage to answer most of the questions. You can.
There was this question on narcotics, which we didn't fully answer. I think what would we do if a patient is already on narcotics? And this is something that we don't have experience with. This is something that you should tell us what you do.
So narcotics, we are trying to get them off by using, as you suggested, pregabalin drugs. It is very difficult once they are on it, unless you have a very motivated patient who is willing to stop. And for some reason, oftentimes they're also smokers. I think that's a bigger challenge now than we ever thought. In the last few years, the focus has shifted to smoking. So lifestyle modifications, and in a motivated patients, we are trying to move them away from using opiates to drugs like Neurontin to see if there's a response. Then we can probably see if endotherapy would work, but it's a very difficult population. I don't have an answer. As you suggested to earlier, we try enzymes in some of these people, but response clinically has been suboptimal. There's nothing that I can say this is a winning formula that we should use, unless you have any other suggestions.
No, I think these are difficult populations, and unfortunately, we don't have.
There are a couple of questions. If you can have we have a couple of questions. If we can have very brief answers so that we can answer all of them. One is an inflammatory head mass. Will you approach with direct surgery, or will you do a biopsy in these patients and then decide?
No, we go for surgery directly.
So do you always do a pancreatic sphincterotomy before putting a stent in the pancreatic duct?
In most cases, because we have removed stones or strictures, tried to put in multiple stents, so we almost always do a pancreatic sphincterotomy.
Dr. Sudhanshu Patwari from Ahmedabad wants to know that in a patient with hyperparathyroidism, after parathyroid surgery, will you still manage it with endotherapy, or will you wait for some time?
Yeah, this is a very good question. We have had a large series of patients now, hyperparathyroidism operated, and we find that once surgery is done, slowly over a period of time, the small calculi in the duct tubes dissolve and go off. But it is a large stone causing obstruction to the main pancreatic duct. This has to be removed endoscopically.
All right. I think I'm going to take the executive decision to bring this session to a close. Thank you, Dr. Nageshwar Reddy, for this interesting and very informative and useful discussion on a clinically very relevant problem. And I would like to thank Dr. Mahesh Goenka, my co-moderator, and ISG, Dr. Nijavan, for collaborating with the ACG and doing the ISG ACG virtual grand rounds. For those of you, this session is recorded, so those of you who would like to go back and listen to it or pass it on to your colleagues and friends, it is available on the ACG website. Members can access it. Non-members can also access it by signing up. So please take advantage of it. Also, I'd like to put in a plug for the ISG annual meeting, the 64th ISG Con. That's on December 21st to 24th. Please save the dates. Within about 10 days, we also have the ACG Best of ACG that Dr. Goenka and I will be moderating at Chennai, Mumbai, and Delhi on 10th, 11th, and 12th. So please try to attend those meetings as well. Thank you all for your attention. I would like to thank the college and ISG for this opportunity.